Hello, Kalimera, Kalispera. It is my pleasure to be with you to talk to you about the updates on heart valve disease and TAVR. What's next? I'm so sad to miss the in-person meeting and delivery of this lecture, as I've had to travel for the American College of Cardiology as its vice president. But I'm really, really thrilled to be able to at least come to you via this recording. Today, we'll talk about updates on heart valve disease and TAVR. What's next? These are my disclosures. There's obviously no question that we've made huge progress over the last 2 decades. If you recall the very first patient by Professor Alain Cribier in 2002, April 16th to be exact, was an inoperable high-risk patient who survived the operation. Over the last 20 years, there's been so much progress from high risk to intermediate risk to low risk, and now the 2020 guidelines giving the class 1 indication as TAVR first in certain patient populations, and to 2025, where an asymptomatic severe aortic stenosis patient should have an early TAVR. And it is a very, very incredible progress. What's happened is that the annual volumes of TAVR and SAVR cases are there. You see through the STS, ACC, TVT registry, and high level of growth over the last many, many years, but certainly massive growth in terms of percutaneous TAVR procedures compared to surgical aortic valve replacement that is actually taking a dip. And we're seeing this growth in young, intermediate, and low-risk patients. You see these data from the data sets that are available, and very, very importantly, from our STS ACC TVT registry. And a very important growth of low-risk patients, especially in the last 5 years. And what we need to think about when we're talking about young patients is the lifetime management of patients with aortic valve disease. Would it be SAVR, where you're the younger patient, and then in 15 years, a TAV and SAV, and then another TAV and SAVs to get that patient to 95 years of age? Or is it to go to the higher risk surgical patients who then receive TAVR and TAVR and TAVR, and of course get them to the age that they could live by? And certainly in the low risk population, when there's been an individual patient data meta-analysis, we see that the stroke and death rates, in fact, the death rates are in favor of TAVR, but the combination of death or disabling stroke even on the favor of TAVR. But the very important difference is that we absolutely need to think about that even in the low-risk patients, but is this the right way forward, given that we need to manage these patients for their entire life, for their management of aortic stenosis, the lifetime management. But I think this study really pulled you aside with the early TAVR trial in asymptomatic patients with aortic stenosis that was published in the New England Journal of Medicine by Philippe Généraux in 2025, simultaneously with his ACC late-breaking trial presentation, when they dared to go after the asymptomatic patients who were deemed asymptomatic with severe aortic stenosis, and yet you see the separation of the curves in the TAVR patients with the numbers needed to treat at 6. Now, obviously, it's almost difficult when you're not doing a sham procedure to basically say that, okay, when you know you have severe aortic stenosis and half of the time you're going for surgery, that these other patients presented with need for aortic valve replacement, which was some of the things, but there were other events as well that separated these patients out in favor of this, and the FDA has approved this indication now. Why this is important is that over time, we've also seen a major reduction in TAVI complications with all of the new device technologies And of course, you know, even cerebral embolic protection and better understanding on how to do with things. And in fact, in this small annulus, we were able to look at two different valve systems for the very first time, self-expanding versus balloon expanding valves, with the very important primary outcomes of valve dysfunction, as well as the composite mortality, disabling stroke, and heart failure for non-inferiority and superiority for bioprosthetic valve dysfunction, which actually deemed to be extremely meeting both of those very important outcomes, the primary outcome meeting non-inferiority for self-expanding versus balloon expandable valve for mortality, disabling stroke, or heart failure hospitalizations, but the self-expanding valve being superior in bioprosthetic valve freedom from bioprosthetic valve dysfunction, which was much, much lower in self-expanding valve compared to balloon expandable valve. And the superiority was also powered for women, which made a large majority of these patients. The new platform and tools to improve the outcomes are also there for very important guide wire technology, very important procedural optimization with cusp overlap technique, and then cerebral embolic protection to hopefully preserve some disabling stroke, maybe prevention, but I'll show you some of the data, but also coronary access for lifetime management with important changes in the devices that we currently have available, and also for devices that are open for future TAV and TAV. The cerebral embolic protection devices have gone through a very, very difficult course with a large patient population that was done in the NHS system in our UK colleagues with over 7,700 patients who deemed to be suitable for a sentinel CEP, an opinion of the treating physicians without knowing the CT. Patients were randomized to TAVR without CEP versus TAVR with cerebral embolic protection, and basically showed absolutely no difference. Even though in a, this was an ITT analysis, but those who got cerebral embolic protection that the physicians thought they should be able to get it, 20% did not receive it. So it makes it very, very difficult to look at this and say that there's absolutely no benefit. But what's next is what's exciting. TAVR for bicuspid aortic valve, where we absolutely need more data to better understand this, because what we know is that it's probably safe and feasible, that it may be okay for 1-year mortality, the results improving with newer generation. CT is mandatory for procedural planning, and that this calcified raphe and highly calcific leaflets are associated with poor outcome, and especially if there's aortopathy there. But I think there are very, very important unanswered issues that we could actually find a place forward for TAVR in bicuspid valve, and that's going to happen through the Navigate Bicuspid trial, where it's a Bayesian and adaptive analysis and a very important event-driven approach, where we are looking at patients who are going to be equipoised for SAVR versus TAVR for bicuspid aortic valve, and Professor Windecker and Uni and Siepe are running this study with a long-term follow-up, and we will see what these data will show. In moderate AS, we have a lot of interesting ongoing trials that are going to be presented. The very first one was an overall negative study with TAVR on load with 600 patients, but now we have Expand TAVR 2 and Progress, where we're going to look at these patients in moderate aortic stenosis. And then TAVI for aortic regurgitation. This is an entire new area that I think is going to be growing, and it's very, very promising. We have the Align AR trial, where it's high-risk symptomatic patients with aortic regurgitation, where the technical success in a single-arm study looks extremely good. And I think for evaluation with a OPC, it looked very, very good, but I do believe we need randomized clinical studies to get this trial approved and this device is approved for pure AR. But in high-risk patients, maybe this could be better, and I think it would be great. The last but not least is if we could prevent aortic stenosis progression. Can we stop it? Now, there's been a lot of work that's been done with all these negative studies that makes it very, very difficult to go there. If you look at the early randomized clinical trials, there's a whole graveyard of them where we see no effect whatsoever on intensive lipid lowering, whether it's with simvastatin or ezetimibe with aortic stenosis or intensive in calcific aortic stenosis. But I think the DAPA-TAVI's trial gives us a lot of hope. This was a randomized one-to-one patients with patients who had diabetes. And at the time of hospital discharge after TAVR, they got a randomization to DAPA versus no DAPA. And what an amazing effect. These patients are absolutely gaining the benefit. It makes you think that there must have been some remodeling due to aortic stenosis and that maybe we even need to, in early TAVR, get to them even earlier. But dapagliflozin and these newer therapies are very, very exciting. We, of course, need other areas to look at, Lp(a) being associated with calcific aortic stenosis. There could be a very, very interesting correlation, whether or not reducing the Lp(a) early, we could avert or change the progression of this disease needs large clinical trials. So, my dear friends, for a take-home message and summary of what I've just told you, the last 2 decades have been amazing, disruptive for TAVI, expanded from inoperable patients to the lowest risk and even asymptomatic patients. The device innovation has reduced complications, improved outcomes, especially with challenging anatomy. And we are now broadening to bicuspid valve, moderate aortic stenosis, and pure AR. And now the future focus has to be on valve durability, personalized device patient matching, adjunct therapies, multimodality management, and prevention of aortic stenosis progression. Thank you so much for your attention. Ευχαριστώ πάρα πολύ.
So this was an amazing talk, very concise, very informative. So maybe in the future, a conference like that will be redundant because we are going to preemptively treat aortic stenosis, George. So what's your take?
Yeah, of course it is. Until the studies are designed, the work is done, and there is enough budget to pay for these expensive medications over the years, that's going to be about the time all of us will be retired. Yeah, but we need to teach the current students, though, because that's going to be a problem they're going to have to deal with.
I think as long as I don't see Medtronic doing any pharma business, maybe we feel safe.
Now, I think we have to refer to the special session we had yesterday about the economics and see how that's going to pan out and how it's going to be figured out, fit in the budget.
Maybe this is the shape of things to come, yes. Maybe.
I have to move the special session to today, so take into account all the knowledge of the conference and have a second special session.
Maybe the universal bin counters, would take notice of that. So, good. So, if there are any other comments, we will proceed to satellite symposium.